Now let's move on to the new immunotherapies. And one advantage, as I said already, is that all these immunotherapies went to meticulously designed and rigorously performed RCTs across many countries all over the world. And the second advantage is that they also tackle and target basic pathophysiological mechanisms that are relevant in NMOSD. And the most far downstream is the complement inhibition. So we have two drugs, eculizumab and ravulizumab, that kind of prevent or work here at the C5 convertase, the cleavage of C5 to C5a and C5b, and then kind of impact the membrane attack complex and also other inflammatory processes, again far downstream. Then we have B-cell depletion with inebilizumab and rituximab, an anti-CD19, anti-CD20 monoclonal antibody. These are not identical. It's important because inebilizumab also targets plasmablasts and covers the broader range of the B-cell lineage, in contrast to rituximab. And then we have satralizumab, an anti-IL-6 receptor inhibitor that approaches and addresses the cascade in NMOSD on multiple levels. For example, the T-cell interaction, driving T cells towards a more pro-inflammatory Th17 phenotype. IL-6 also acts on the blood-brain barrier and on astrocyte injury, and many more that are beyond the scope now of this talk. And this is a nice slide. We have now 4 approved therapies in the US and in many European countries and a few other countries in the world. You can see the mechanism, the target here. You see the route of administration, the dosing schedule, and the associated clinical trials. And this briefly summarizes the clinical trial. It's a bit busy and text-heavy slide. I will just mention the key points here. So for complement inhibition, this was eculizumab and ravulizumab. The trials recruited only aquaporin-4 IgG positive patients, in contrast to the other studies. There were 2 studies with satralizumab, Sakura Sky and Sakura Star, one with background immunosuppression and the other one a mere placebo-controlled study that also enrolled some seronegatives. And then the Momentum study, in terms of patients enrolled, the by far largest trial with 230 participants, a mere placebo-controlled trial with a shorter period of time and then a longer OLP. I'll come to that in a minute. That also had a very small fraction of seronegative patients. And this again is a busy slide. I just want to direct your attention to the last line. This is the risk reduction for aquaporin-4 IgG positive patients, and these are the patients in whom these drugs are approved. They do not work probably, and they are not approved to treat seronegative patients. So you can see here that we have an almost 100% risk reduction in the 2 complement inhibition studies. Here it has to be mentioned that there was no placebo control in the study. A historical placebo group was used from the PREVENT study, and you can see here in the range of 70 to 80% risk reduction for the seropositive patients in the 2 satralizumab trials and the 1 inebilizumab trial.